going to do theory part of view, this neurological disease in pregnancy. The thing is there, here I want to tell you one thing, very important thing, you have to realize that thing. What is the meaning of this neurological disease? So it will, all the things in the world, it will come, all the things which is consist of the brain, nerves, all these things will come. See, it is written there, neurological disease are, I'm just telling, then we will go in detail, just only this abstract. So it is commonly encountered in women of the childbearing age, and pregnancy can pose a unique and if not challenging this aspect to their management. A number of the condition exist prior to the pregnancy, and either the condition itself or its therapy may impact on the pregnancy. That's the reason the neurological conditions are very important in pregnancy. So what he wants to say, he just only for the guidance of your mind. It is not for the theory we are going to do, but for the guidance of your mind, that you have to understand what is this the neurological disease in pregnancy going to be mean, that one. So it means, this disease mostly they have prior to pregnancy, and then when they will take the treatment, it will affect on their pregnancy. This is the main thing they want to tell us. Very rare it happens, some this neurological condition will develop in pregnancy. Mostly they are pre-pregnancy, they have the problem, that one. So if theory point of view we will do it, it will be very different if we will do the than the OSCE point of view. So here we are doing the theory, so we have to understand which is important for our theory point of view. Okay, and then he said the pregnancy may interfere with or preclude the optimum treatment. So this is the main thing they want to tell us, that because when you are giving the treatment, she is pregnant, and when you will give the treatment, certain treatment you can give her, certain treatment you cannot give in the pregnancy, and certain management you can do in pregnancy, certain management you cannot do in pregnancy. So that's the main idea or aim of this neurological disease. So what it will consist of? It will consist of headache, migraine, tension headaches, okay, and the migraine. This is the one they have it here. Then what they have it other here, then the epilepsy. This is the most important one, epilepsy. This is postdural puncture headache. This is very important when they are receiving the this one epidural or the this anesthetic. This is at that time, this will be important that for us when they are receiving the anesthesia, epidural, mostly epidural, okay, because they are puncturing, that one we will do it, but not in detail, the only theory point of view, and this is very important article. So the second one, the most important one, which is very common and which we are using it, this one will be the epilepsy, okay. This is only for your point of view, okay. Then epileptic drug, these are very important, and these are the malformation. This table you have to make the ratification, learn by heart. This is the one, what phenytoin will do, cleft palate, what carbamazepine will do, whatever these drugs are, we will read it. I'm just telling that what things we are going to do it here. Then what he is asking it, risk of congenital. So the highest risk will be what? This is the highest risk one, carbamazepine, okay. This is the highest bidder getting the more money. This is the highest bidder in that any company business. So this is the one, the one causing the highest problem, malformation, these drugs. If they will, sometimes they can ask the question, this 3-4 they will give you scenario, and the option they can give you, okay, the scenario will be that's what, absolute risk of the congenital malformation arising from anti-epileptic drugs, monotherapy. We have a monotherapy or multitherapy. We are talking just now about the monotherapy. If any monotherapy, the highest bidder will be what? Carbamazepine. They can give you lamotrigine, phenytoin, sodium valproate, because most of the people we are thinking about the sodium valproate. This is the culprit. No, this is not the culprit. Culprit is the one, carbamazepine. This is the culprit who is doing the most important malformations, congenital malformations. So we have to know that one. Then what we have it here, this all blah blah will be important for the theory point, OSCE point of view. Here we have to know little, but we are not supposed to go detail about the and the pregnancy, okay. This is the thing we have it, and then the other things what we have to have it here. Here postpartum care and the multiple sclerosis, okay. This is affecting the CNS. This only just I'm telling which were the one. This is only a small thing we have to know about thing, no more than that we will go. My dear. Okay, it is coming. Can you see it? Okay, it is coming. Okay, so this is the thing. Then what is the one a risk factor for the stroke during pregnancy? So this is the table we have to know. Not more than that one. This is for the stroke. Then what we have it here, cerebral venous thrombosis. You know, this is a very important topic. The small topic. This is small, unrelated topic, but we have to know that thing. Then myasthenia gravis, and this myasthenia gravis, myotonic dystrophies. This is all the thing in the word. It is there. We don't need more than that one. Peripheral neuropathies, cerebral tumors. So this neurological disorder, Bell's palsy, it will be in the Bell's palsy. So this will we have to finish like this. There is nothing Carpenter syndrome means. I want to say this neurological disease disorders in the pregnancy, what it will be consist. These are the things which we supposed to know. We are not going to have it more than that one. 1 minute, please. Okay, so this one I want to say it. We have to do this thing. A theory point of view, most important is the epilepsy and epilepsy malformation and the drugs. These are the separate tables which I already put in the group. So you can take it from there. Okay, more. Means what are the differential diagnosis if you look for that one. Okay, in it is it's all not the table, not all the tables are important there for theory point of view. So please like this type of tables, so you can have that table there. I can have it here. The most important one with which we have to do it today, it will be epilepsy. But see here the other things, this migraine and tension headache, if you have time you just only give a reading of that one. The other topic if we will let it, but I will try the first important one, epilepsy, and if we have a time we can do that one. Otherwise you can have a time, just have a look, just don't go in the detail. I will tell you how we will finish that one. The most important one is the epilepsy. So epilepsy first is theory point of view. We have to understand what it will be. It will occur in 0.5 to 1% of the woman. Okay, and this and you know the condition has to be most common, rare, and very common. Like they have given like this one, like the risk factors they are dividing when we are counseling to the patient. So it is the same thing. If you will know all the, I told you all the neurological disorders. Okay, to complicate the pregnancy. I told you, na, tension, headaches, this stroke, cerebral, this one, venous congestion, all these things if we will make it collectively. So the most important, most common is the epilepsy. This is the question. The question can be like this. I'm saying, what is the most common neurological disease to complicate the pregnancy? It is the epilepsy, and 0.1 to, 0.5 to 1% of the woman. This is the one, and the most important nowadays. Sorry, I will let you know in the group this thing. We have to do this thing. This Embark UK report. They are giving the yearly now. I think it is 1 to 2 yearly. They are giving the reports in 1 year how much women are died and how much it is the risk, and which is the top one problem which the woman letting to die. So they divided the death of the woman, this mortality divided into direct and indirect and coincident causes. But if we will consider about the, I will do it direct, indirect, and all these things. I think inshallah Friday, no, not Friday, Saturday we'll do inshallah ya Rabbil Alamin. So this is the one which is, this is one of the leading cause of indirect death. Indirect death, what is the meaning of indirect death? See, we have a direct death and indirect. Direct death means I will punch you directly. If you want to punch me, you can punch me directly because you are present there, and you can punch me thumb in front of me, you can punch it. Indirectly means you will ask somebody, I will ask somebody to punch you. So this is called indirectly. I want bad for you, but I am not the one who is going to do, but somebody else is the one who is going to do that bad thing for you. So the same thing which I want to tell you here, the epilepsy is already present. Okay, and it will make the complication for it, but it not means develop during the pregnancy to make the problem in pregnancy. I am clear so far? Hello, my dear.
जी जी।
Okay. So this is the thing we have here. What is important for us? 3 points are important here in this one. So please write in your the one which I told you already where to do the things. So 3 points is important for us in this epilepsy. The percentage 0.5 to 1%, and the most common neurological disease and the indirect cause of death. That's all. These are the 3 points which you have to remember. Then what is the classification? Then we have to go about the classification. Classification according to the clinical type of the seizure. Why they say clinical type of the seizure? Here we are not talking about the pathology. It's about the clinical. What the patient has a clinically. So they divide it according to that one, classified that one. And EEG, electroencephalographic appearance, which divides upon the clinical features, and ECG appearance which will appear, and it will be the partial or the generalized. The most common forms are what? So what they divided it, the question will be not like this. For you, this will ask that what is the classification divide upon the clinical type and the EEG. This is mostly important for the point of view of the ASCII. But for the theory point of view, this is the only thing you have to remember, that one. Tonic-clonic or the grand mal seizure. Then absence means pet mal seizures. Okay, temporal lobe seizures. This will be the complex partial seizures, and the myoclonic seizures. So this is what he wants to do. See, the cause. Now we will see upon the cause. Cause of the epilepsy, majority mainly, or we can say mainly, it is idiopathic. There is no cause. They cannot even find the cause. But familial relation is there. Family relation there. In their family, if somebody have a epilepsy, the other person can have a epilepsy up to 30%, 30%, 30%. So this is another what we call it, data we have to remember. One data, 0.5 to 1%. The common is epilepsy. And that when the genetic will be the family history, 30%. And my dear, please remember one thing. Whatever I'm giving you these figures are the world renowned figures, and I'm not the one. So I don't know Pakistan what we have to follow it. We are following it with the MRCUG, and this is the MRCUG. They want that type of these things. Okay, so this is authentic, that one, the figures which I'm giving you. But if you find in your EBM, if you like it, you can check from the EBN what they given it. So you check this one, only check this rates, incidence and these things. No need to go more than that one. Okay, so what we have it here, the majority cause is unknown. Okay, and the 30% of the patient has the family history. What is the meaning of this one? Majority epilepsy causes it, because we don't know. But some, the causes are there. The cause are known, because sometimes they have a operation in the brain. So after the operation, something will goes wrong, so they can start to have the epilepsy. So it will be the secondary, and we know the cause, that she is having the problem during the operation, and maybe she is having a malignancy in the brain, so she start to have a seizures. So these will be other causes, but the majority we considered means without anything we know it, that she don't have a surgery, she don't have any disease. So this one, she is normal there, everything is not a problem for her. She start to have a seizure, it means the cause is unknown. And the important diagnostic investigation for this epilepsy are EEG. Okay, this the up one here, this EEG, this is the one we have to do. Sorry, this is the EEG. Okay, yeah, this one we call electro, sorry, 1 minute, uh, electroencephalographic. Okay, appearance. So we have to know only that. Acha, he say majority of the epilepsies are diagnosed before pregnancy. See, we the same thing. We are talking about that mostly, most of them they have the epilepsy or before the pregnancy, and she is taking that treatment. And maybe she have there some, they have some. Please remember this word, some. Sometimes they are very clever. They want to deceive the person, and sometimes they are very nice. So, but we have to understand in our mind that some means first time without pregnancy, means she is not pregnant. Before pregnancy, she is not known that she is epileptic. Okay, but most. So please remember, most during prior to pregnancy. Some. This is the difference. Some they have a fit in the pregnancy. So this is the difference between this and that one. Okay. The differential diagnosis is the most important point here, very important. But there is a table, I have given you table, it is there in the group. So the differential diagnosis will be there, what it will be there, but here whatever the rating we can see from here, it can be eclampsia, she is pregnant, she can have a fit. So mostly it will be eclampsia, or it will be intracranial mass lesion, maybe she is having any tumor in the brain. And the cerebral thrombosis, another third one cause. Fourth is the stroke, and fifth means hypoglycemia. She is hypoglycemia, she can have the figure of the epilepsy. And the electrolyte imbalance means hyponatremia and hypocalcemia. See, this is the thing, this she will, if hyponatremia, hypocalcemia, she will has a tonic clonic, mostly that one, then twitching of the muscles will be there, so it will be like a jerking movement of the when she is having this fits. So this is due to this reason here, but they given some small, so we have to understand that small one, no? So this is the differential diagnosis, we have to remember that one. So this is the most important part in epilepsy, anti-epileptic drugs. So the anti-epileptic drug, AED, I will just only, why they are very, these, why AED drugs, why they are horrible, because they cross the placenta and are teratogenic. This is the main cause of the, so they will cause the malformation. Clear? My Okay, so please, you have to remember these things. I mean, the ED drugs, why they become so horrible? Because they are crossing the limits of the person. So they are crossing the placenta. Okay, so that's why they are mostly the teratogenic. You know, my this is not in a good mood. The marking, so I have to remove this marking. Anyway, the major malformation, which one are the major malformation? These are the neural tube defects, orofacial clefts, congenital heart defects. So please remember, this is in the side, this is the table 1. Okay, this is the table 1 we have here. Okay, the another one is here if we will go there. The minor malformation was means dysmorphic face. The face features are not symmetrical, it will be dysmorphic. Then she can have a hypertelorism and hypoplastic nails and mid face hypoplasia. Leave them alone, you will never remember, and they will not ask, because mostly they have to concentrate on the normal thing is normal. They will give this abnormal things very rarely. So malformation we have to memorize. Okay, as a summary there, this is the one. I have put two graph there, so two tables are there. I put in the group, whatever you like it, you can do it. Or some you can find there, or some is here, so you can make it also a mixed one, mixed plate, and then remember. Okay, so we finish that one. Then what we have it associated malformation, whatever it is when we have in table 1 and table 2, we have that one. Now he is talking about the sodium valproate is the most teratogenic anti-epileptic agent and is responsible for 2% of the neural tubal defects. This when we are giving the monotherapy, please remember this is monotherapy, but if she will receive it the polytherapy, particularly regime is what, including the what we have, sorry, including the regime include what, valproate, along with that one sodium valproate, and other one will be there, so it will increase the risk of congenital malformation if it is a polytherapy. Okay, so the risk will be more. So we are not going to read it about this one by one, what they have it, whatever they are talking, they make it here in that graph. So okay, so just we see that graph we don't need, because we don't have a time, luxury of the time to remember all this blah blah. The best, this table 1. Okay, now we'll go for, if we will consider about, if we will go pre-pregnancy management. Why we are making it here? Because you see, I already told you that I am not already told you, it is written in this one article, they already written it there. Mostly they have a pre-pregnancy disease. So pre-pregnancy disease, if she knows it, she is a known case, then she has to go before pregnancy, pre-pregnancy counseling management. Why it is important pre-pregnancy? Because 1 or 2 drugs, some drugs are there, they are very teratogenic for the baby, so they have to change then before pregnancy, because sometimes she is continues to take that drugs, and when she become pregnant, the already the time period is gone and baby is start to be have a congenital malformation. So that's the reason they are telling it before getting pregnancy to make the counseling, because they want to counsel about the change of the medication, and they will increase the dose of the folic acid. So what we have it here, pre-pregnancy counseling should be routine practice. It has to be there. If she is a non-epileptic prior to pregnancy, na, we have to there. We have to control the seizure. Okay. Here our aim is least number of AED. Okay, and the lowest possible dose. Just only remember this word. In pre-pregnancy counseling, aim is what? We have to do least number of drugs. Means if she is taking 4 drugs, we will try to make these drugs wean off the one which is making malformation, and then we have to continue the one drugs which is are not making the malformation. So he is telling we have to check for the drugs which she is taking, and then the most important one, we have to reduce the drugs, and dose has to be reduced, because higher the dose, higher the complication. This is the thing they want to do. Okay, so we done that one, and then the analysis they are showing, we don't like it about this thing, for us not so much important. Okay, and then she has to, he says she has a 9 month prior to pregnancy is associated by the he said if she will take pre-pregnancy counseling, so if she remain at least 9 to 6 months free with seizure, then she has a high risk that she can continue she can be pregnant with very least malformation she can have it, because she is seizure free. So the drugs will be using less. That's he wants to say it. Less dose, less drugs, combination of the drug. So 80 to 90% seizure free, they remain seizure free during pregnancy. If she has a pre-pregnancy counseling, they told her which drugs she will take it. It is the epileptic consultant. He is the one who has to make the consultation about her the change of the medication. We are not the one. They are the one who has to know about the change of the medication. Actually in epilepsy, what is happening? Actually, epilepsy, there is a waves in the brain. So they will start to erupt irregularly. So the changes will happen in the brain, and the person always control with the brain. So all the things will be uncontrollable. Mostly it affecting the means the limbs, the legs, and the way she is making the epileptic fit. Okay. So this he want to say about the pre-pregnancy counseling. That's the main thing she can have it there. Okay. Now, if she remains seizure free, remains seizure free, it is there at least 2 years, na. So they can discontinue the anti-epileptic medication. Okay, but it has to be informed decision. For you, it is not important. The only thing important, theory point of view, that if she remains seizure free for 2 years after consultation with the epileptic doctor, they can discontinue. So remember one thing, 6 to 9 months, if she is seizure free, it is very helpful for the pregnancy. She can start the pregnancy. And if she remains 2 years seizure free, then she can stop her medication. Clear point of view, my friends? Okay,
जी
clear. Okay, chale, it's understandable for you. This is the most important continuous. So she can have a discontinuous. Okay, but he say those women who have a juvenile myoclonic epilepsy, they are not supposed to discontinue their medicine, because juvenile from childhood she is having it, this seizures. So these things, and it is a myoclonic epilepsy. Okay, affecting on the muscles. So she is the one who is not supposed to discontinue. So please remember these points in your for the theory point of view. The juvenile myoclonic epilepsy, they are not the one who can discontinue. Even she is 2 years of seizure free or 3 years of seizure free. She is not the one. She is not the candidate. Okay, anyway. Then he is talking about those women who is taking the sodium valproate. We have to tell her in pre-pregnancy that she has to take the alternative medication. Okay, and then she has to do what? And lowest dose she started. But the problem is that some they, whatever you will do, they cannot they cannot control her seizure on other medication. Then you know what happened as a I'm talking about the way they are taking the things along with them. So she has to they have to inform her that if she will become pregnant, if she is on the reproductive age group, then she is the one who has to fill the form that she already knows that the malformation can occur, because this is the one top medication which will make the malformation. So she has to fill the form. I'm just talking about another point of view, OSCE point of view, that she has to fill the form, that she has been informed about the baby congenital problems, because if they will not eat and she get pregnant and baby born with congenital abnormality, she will take that doctor to the court that he did not or she did not tell me. So this is not the way. She wanted to do that one, and they knows it. It's whether it is from your clinic or whether she is following up with epileptic doctor. They are the one who has to know that to fill the form that she already a doctor inform her, but she is the one who is who want to that medication. So this we finish this very important point. And then sodium valproate we are talking about. Then what she has to do, try to go, switch it, alternative. Okay, switching alternative AD. Okay, because it is pre-pregnancy counseling we are talking it. And another name of sodium valproate is Epilium. Okay, this is the dose. But if she has to be deemed appropriate, not appropriate, we can change it. But if it is deep appropriate, that we have to continue that medication, so we have to do the lowest dose, slow release we have to use it. And that because they have a high risk of neural tube defects. Okay, so if she has a plasma concentration lower, so the risk of the neural tube defect is reduced. So we have to check the most important one, the risk of the neural tubal defect. So we have to understand that one. Okay, so now we have to do, these are the malformation table. Please again try to remember that table. We done that one, and this already I am telling you it is the most culprit one. So we finished that one. Now we'll start about the antenatal care. In antenatal care, the if there is a uncontrolled epilepsy, okay, then it will be a risk, a very risky to the mother and the baby, both of them. Okay, and the we have to know tell that there is a risk of teratogenicity also there, and a baby can have a childhood neurological neurocognitive behavior problems. So this is a very horrible if the parents having this neurological neurocognitive developmental problem for that type of babies, because this all blah blah will occur due to the period of the hypoxia during the seizure time, na? Because if she is having a hypoxia and she is having a seizure, what it will happen in seizure? In epilepsy, what is actually happening? Please try to remember. In epilepsy, it happening that her brain deprivation of the oxygen will be there, because she is having a seizure. Seizure means she is making the seizure, having the seizure, sorry, and the oxygenation is not going to the brain. What is the meaning of oxygenation? Means there will be a disruption of the blood supply will be there. If there is a disruption of the blood supply, because she is making fits, she is having a fit, so how the blood will go to the brain? Within 5 minutes, blood will not go to the brain. She will be, baby will be hypoxic, and mother time to say bye bye will be there. So that's why they are very afraid with this 5 minute hypoxia can happen to anyone. So okay, so they say about this one, she can have a then afterward she is having a excess, she can have a prolonged or recurrent episodes of that one, which will be harmful. Okay, so say maybe the cause, we have to look about the cause of this one, why she is having this problem. Sorry. Uh, so what he is telling it, more likely, because you know in the prior to those women who has a uncontrolled epilepsy prior to pregnancy, they are more likely to experience increase in seizure. So if it is not controlled, she will have an increased risk of the more seizures in the pregnancy, both in that frequency during pregnancy and poor control she can have it. So what we do? A lack of the drug compliance. What is the reason? We have to look. What is the reason? One of the reason will be there. One of the reason will be there that it will be a lack of the drug compliance. She is not compliant woman. That's why she can have a risk, or there is a decreased level of the blood due to maybe she is having a vomiting. Okay, and maybe she is having a free drugs levels, carbamazepines and lamotrigine. Lamotrigine. So the lower free levels of the drugs. Okay, and she has a decreased gastrointestinal absorption. Absorption is not good, so she has a decreased absorption and the lack of the sleep, because the he is talking about why she has an increased risk of the seizure. This is the answer of our question, my dear. So we have to understand that increase seizures frequency. Okay, and increase seizure frequency during the pregnancy. She has have had this problem. So what he is talking about during the pregnancy? Sorry, my this one is not working. Anyway, so this is the reasons he given it, and then he say we are not supposed to discontinue. This is the most important point. Option to discontinuation of the, sorry, 1 minute. I will try to get option for the discontinue AD. She has to carefully think, because abruptly, if the drugs are discontinued, she has an increased risk of the seizure. That's the main thing he is doing. So the seizure activity may resume or increase. It will increase when, if she is not having this one, seizure free maybe 6 months, 1 year, then if we will discontinue abruptly, she can has an increased risk of the seizure. She is having it. Okay, this what he wants to say. And on the top, if she become pregnant, she will be in the problem. Okay, this drugs will make it. So he is talking about that. That he say we have to counsel restarting AD with regular seizure if she is having, especially after the first trimester, which is the risk of tetragenics. Okay, has passed. So whatever, even she is taking some tetragenic medication, first we have to stop, because this all problem happen in the first trimester, and afterwards consultant to the epileptic specialist, she can resume her drug, but it's upon them. Okay, the discussion and the facts, she is having it. Anyway, so we finish this thing, and then he say baby also have a risk. Please remember that thing, that if she is having a, we just remember, you remember we have told you that she has a 30% risk of the epilepsy during pregnancy. Okay, if she is having a familial history, the genetic one. So the same thing he is telling. All this blah blah he make it that because the woman, she is having a seizure, especially after the first trimester, then the risk of tetragenesis have passed, because mostly the tetragenic effect in the first trimester. Anyway, then what he wants to tell it, she has to receive folic acid. Folic acid, 5 milligram. Not pre-conception. She can have it, and she can continue this throughout the pregnancy. Clear? This is the very important point, that folic acid 5 milligram, because regularly we are giving 4 milligram, but here we have to increase the dose 5 milligram. And those on the carbamazepine, valproate or lamotrigine will exhibit little proton inhibiting and may need to increase the dose. So right now we are not talking, because each and every word we cannot remember for the theory point of view. So the thing we given it. So a baseline serum AED level may be useful in establishing the compliance, because we are talking about the patient, maybe she is not compliant, that's why she is having a seizure. So he is telling it, okay, if we want to do something better, what we'll do the baseline plasma level of that drugs AED which she is taking. So we will understand that there is a compliance is there or not. Okay, and then we can also adjust for the future doses, particularly who have a regular features. And this is the most important thing, vitamin K. We will give her vitamin K, should be prescribed from the 36 weeks. Last 4 weeks we'll start the vitamin K. Okay, if she is taking the enzyme inducing drugs like phenytoin, carbamazepine, phenobarbital, and primidone to increase the vitamin K, sorry, which increase vitamin K dependent clotting factors in the baby, and reduce the incident of hemorrhagic disease in the newborn. So he telling about the benefit of vitamin K. So he's telling we will give the vitamin K last 4 weeks. Please remember. And if she's taking the non-enzyme inducing drugs, which are the non-enzyme inducing drugs, you have to remember, please remember this thing. What are the non-enzyme drugs? Phenotine, carbamazepine, phenobarbital, and pyrimidine. So 1, 2, 3, and 4 they are giving, actually they giving the 4 1. And what we'll do, we will offer her the ultrasound in the first trimester. We'll do as a screening test. Anomaly scan we'll do afterward 18 to 22 week. So in that one we will include the fetal echo. We'll see also the same time when we are doing anatomical scan, the thing we have to do about the fetal echo for the fetal malformation. Okay, and we have to tell that to the family members, if she will fit, how they can manage her in the home to the recovery, for the recovery position. They have to change for them that position. Okay, so this one we finish it here. And then intrapartum one. Intrapartum means is not contraindicated vaginal delivery. Please remember this thing. Is not contraindication of vaginal delivery, and seizures should be performed on obstetrical indication or the event of risking generalized in labor. What he say? He is telling it. Vaginal birth is not a contraindication, but she has to have a cesarean section. Because the obstetrical indication of that one, what she is having, if she has a recurrent seizure, if she is having it, so she has to change it sodium valproate. And the seizure recurrence is higher during labor and in the first 24 hours after delivery. Please, this sentence by heart you have to remember. Recurrence will be more common. 1 second, I will first finish this one. Okay, so I hope now it's clear. That's why I try to write it in the red. So he is talking about the seizure recurrence is higher during the labor and in the first 24 hours after delivery. So please, this is a very important MCQ. Seizure rates are higher during the labor and the and about the post delivery 24 hour means 1 day she has to be observed. That's the reason. Okay, so we finish this thing here. Anti-epileptic drugs should be continued throughout the labor. See, this is another important. We are not supposed to stop the medication if she will come to us in the labor, na? Or she is in labor. So anti-epileptic drug during labor we have to continue in the suppository form, because if we'll give orally, it will take time to affect it. So that's the reason he is telling about that we have to do about this one during labor. A suppository form we can give her this anti-epileptic drugs. Okay, he say if necessary in the event of the seizure, women should be managed with facial mask, intravenous lorazepam, and rectal diazepam. Please remember this word also, very important, this one. Even if in the event of if she is in laboring and she takes some medication of her anti-epileptic and she start to have a seizure, so what we have to do, we have to give her the oxygen, IV lorazepam. This is the most important thing they are talking. Lorazepam, not drugs is change, or a rectal diazepam we can give to her. The postpartum, what we'll do? Postpartum, sorry, not mortem. If she has a sleep deprivation, will lower the seizure. She has to take a good rest, good sleep, because if she will not sleep, take a good rest of the sleep, the baby woman, this one's postpartumly. So try to, she has to take nice support at home. Okay, ji, to minimize the risk of herself and the baby. That's the main thing he is talking. Then he is talking about neonate, they also have to, after delivery of the baby, they have to give the neonatal IM injection of the vitamin K. That's what he wants to say. So we finish up to here. Sorry, 1 minute. These are the things, the very important topic. This one, this